This conference will now be recorded.
Okay. Good afternoon, everybody. Is my voice
Good afternoon.
clear?
Yes, sir.
Okay, good. So I'll request everybody to kindly switch off their mics at this point of time. Today I have purposely selected an organ which had, so to say, fallen out of favor from the surgeon's armamentarium until the interest was reignited by the generation of bariatric surgery. Now, initially, the stomach was a very well-read and a very well-understood organ way back in 80s, when a lot of peptic ulcer surgery was being done at that time, both for ulcers non-malignant and complications of ulcers. But gradually, with the advent of PPIs, the ulcers almost disappeared, and we were left only holding the bucket with our duodenal perforation, which was the only thing which came to the surgeon. The rest of it was almost removed from the surgeon's armamentarium, except of course one part of the stomach, and that was the malignancy of the stomach, which in no way is very benign kind of malignancy. It's a very malignant tumor, so to say, right? So I thought of picking this organ up because now it is a fresh interest has been generated with the advent of bariatric surgery. And there are other reasons also, because even the ulcer is now coming back. Okay, so we'll start this part one of a series of lectures of 4 parts. So the first one, you'll be dealing with surgical anatomy, physiology, and combined Helicobacter pylori and other gastritis, right? Now, okay, so just the macro anatomy of the stomach, you would say, or you would feel that you know everything about the stomach, but no problems. Let's just repeat it. And the major part of the stomach lies in the epigastrium and the left upper side of the um, abdomen, and it's a muscular, highly vascular bag shaped distensible organ. And if you look at the size of the stomach, it's almost the size of a fist, but can stretch to hold as much as 4 liters of food and fluid. See the amount of stretching it can do is almost 75 times of its empty volume. And the best part is that it comes back to its resting size when it's empty. Okay, so it can take varying shapes depending on the build of the person, depending on the posture of the person, the state of fullness of the organ, and of course the contents of the organ. The anterior surface, we all remember, is related to the left lobe of the liver, which now is known as a segment 2, segment 3, and part of segment 4 of the liver, the anti-abdominal wall, and the distal transverse colon. They're all in anterior relationship to the anterior surface of the stomach. And the posterior surface of the stomach closely related to the left hemidiaphragm up, and caudally coming to the spleen, part of the spleen, laterally and caudally, and posteriorly the left kidney, adrenals, and the pancreas, which form the stomach bed. Now, the parts, if you look at the parts, the incisura angularis, and how would you recognize this from the outside? You all know that when you have the stomach in front of you, there is a junction of the vertical and the horizontal part. There's the vertical and the horizontal part. That's the incisura for you, right? And if you draw perpendicular from this to the greater curvature, this is a perpendicular, 90 degrees angle out here. It's a perpendicular from this point to the greater curvature that demarcates the left and the right stomach. The left stomach is basically the fundus and the body, and the right stomach is what we know as the pylorus. And the pylorus has got 2 parts to it. One is the pylorus proper, and number 2 is the pyloric antrum, right? And the pyloric antrum and the pylorus are separated, what we know as the sulcus intermedius. And the sulcus intermedius is fairly constant, about 2.5 centimeters proximal from the duodenopyloric constriction. So this is roughly 2.5 centimeters, right? Now, the fundus and the corpus, we look at them together because they have more or less same kinds of glands, same kind of cells. This is built up of parietal cells and chief cells predominantly. And the mucosa of the antrum is predominantly mucin-producing cells and specialized endocrine cells. And the endocrine cells, 50% of these are gastrin-producing. Now, the mucosa of the incisura is basically a confluence of 2 types of mucosa. From up, it is basically the predominantly the acid type, which is the corpus, and the admixture with the antral mucosa. So it's got an intermediate mucosa. Okay. Now, if you look at the attachments, which are very important for the surgeon, and starting from above, we got the hepatogastric ligament. You all know the hepatogastric ligament, also the lesser omentum and the free edge of lesser omentum. We know has the three important structures, which are the hepatoduodenal part of the ligament. This is a part extension of the right end of the gastrohepatic ligament, and got the three parts to it, and rather three organs lying in the free edge, and starting from the right to the left, you got the bile duct, you got the hepatic artery, and posteriorly got the portal. We all know that. Now, why is it important though? Importance as far as is concerned is mainly when you're trying to deal with malignancy of the stomach. Why? Because now we know that D1 and D2 excisions of the malignancy of the stomach, they entail removal of the lymph nodes. Now we'll come to that when I talk about the malignancy. But at this point, what is important anatomically is that if you want to approach those lymph nodes, you want to approach the left gastric artery, the right gastric artery, you have to go through this ligament. You have to open the leaf of this ligament, only then you will track down the left gastric artery and the right gastric artery. Right? The gastrophrenic ligament, which is out here, this is basically attaching it to the diaphragm. And why is it important? Because until you do a complete excision or rather separation from this ligament, you'll not be able to do the angle of His. And that becomes very, very important when you're doing a sleeve gastrectomy. So all this has got basically applied importance to it. Okay. Now proceeding down, you come from the top, the cranially caudal, you have the gastrosphenic ligament. And gastrosphenic ligament is again very, very important. Why? Because this is the best part where you can approach the lesser sac. Now, if you try to approach the lesser sac from the part where it is the attachment only the greater omentum, you'll not be able to enter the lesser sac. You'll not, right? So the best part to enter the lesser.
Sorry, sir, we can't hear you.
Means what? Removing the gastrosphenic attachment, doing the gastrosphenic attachment. Okay. Now, the gastrocolic part is basically a part where you have the major attachment of what is known as the greater omentum. Just talking about that in the next slide. And behind the stomach, you'll have a free peritoneal bands which will be present between the posterior of the stomach and the anterior of the pancreas. All the residents must be knowing when you've done the exploration of the lesser sac, when you don't find a perforation, you know there's a perforation somewhere. You explore the whole of the anterior part of the anterior surface of the stomach, you don't find the perforation. It becomes imperative that you go to the lesser sac before you can look at the posterior surface of the stomach. So that is very important where you have to open the stomach, and that time you will see that often you find attachment between the posterior surface and the pancreas. So just a few attachments there, right? Now this part of greater omentum hangs like a apron from the lower surface on the greater curvature. It hangs from the greater curvature. Now this basically has got two layers anteriorly, two layers posteriorly. And it's very important to understand that, right? Why? Because if this is a stomach, this basically is a sagittal view. You've got the two layers, and the two layers join together. So this is the area where you got the greater curvature. It's coming down. Two of them are coming down. And the two of them, they fold up until they reach the pancreas, where one ascends up. So this forms the boundary of the lesser sac. The boundary of the lesser sac is layer 2 and layer 3. Take from here layer 1, layer 2, layer 3, and layer 4 of the omentum out here, right? So layer 2 and layer 3, in between is the angle layer, lesser sac. And from the anterior surface of the pancreas, one layer goes up, forming the posterior surface over the retroperitoneum, and then getting reflected here from the diaphragm. The other one gets reflected across the anterior surface of the pancreas and form the transverse colon, and then comes to the transverse colon, again going back on itself and then forming this. This is the retroperitoneum. You're looking at the retroperitoneum, right? So transverse colon is formed out here. Now this is how it looks like. This is basically a diagrammatic representation. Do you ever find this kind of a space in between? Hardly ever. Hardly ever. This is what we find. We find the whole thing is stuck together. But in actuality, what is there? This is both 1, 2, 3, and 4 stuck together. All 4 layers out here. But from here, you can easily segregate the layers separately. You can see them separately. So this is important to understand. That is how the greater omentum is built up out here. Okay. So that is important for us. Why? Because we try to enter in this particular area, like example, we try to enter from here. It will be very difficult to enter the lesser sac. Instead, if you try to enter here, very easy to enter the lesser sac. That's what I was saying. That if you have to enter the lesser sac, always go through the layer of the peritoneum, or rather layer of the omentum, which is beyond the lesser curvature but lying in the upper half. That is very important. So this is the area. This area, always enter the left sac from here. Never try to enter from here. You'll not be able to enter. Why? Where do you land up with? You straight away go and land up with the transverse colon underneath. You'll be having all the 4 layers in front of you. Here you just have 2 layers. So here is the entry point. Never forget this. Right? Right. Now, if you look at the macro anatomy, we all know the various shapes it can have, the steer-horn type, the J shape, the sickle shape, and all those shapes. Gastric canal is an important constituent, and this is basically a physiological canal we're talking about. And this is roughly a canal which lies or runs along the lesser curvature. This is basically the gastric canal. And what is this gastric canal, or Strasse it's known as? This is basically a canal which is not there anatomically, but as soon as the food reaches or exits the lower end of the esophagus, coming to the stomach, immediately the contraction of the muscles, especially the oblique muscle, that leads to a preferential canal formation, so that the food is directed. Initially, it is a liquid which is directed, and then the mixed food is directed from here. It comes down to the pyloric area. The pyloric area, the muscles churn the food and they throw it back. So it comes like this, churned out here, and it's thrown back into the fundus and the cardiac area, giving it time for digestion. So this keeps on running. It's a mill type. I think mill type. So it is coming from here and then going back here. If you look at the mucosa, the whole of the mucosa is smooth, soft, and velvety. Those who have seen an OGD being done, or those who have seen pictures of OGD pictures, they would know that it's basically a velvety kind. If you have done a OGD, you've seen it done, you also feel it's a soft and smooth, right? In the fasting state, it is pinkish tinge at the pyloric end and it's thicker. It's always thicker out here. See the thickness out here? It is thicker in the pyloric area and relatively thinner out here. Okay? Red or reddish brown over the rest of the surface and thinner at the cardiac. Okay? In infancy, brighter hue, the vascular redness being much more marked. If you look at the mucosal folds, normally in the collapsed state, they are very well perceived. That's in the contracted state, right? And you find them in numerous places. And what is being folded up? It is both the mucosa and the submucosa. That is being folded up to find the mucosal fold, right? And this contracted state, you'll find that they are longitudinally directed. See these? Can you see these longitudinal directions? That is how it looks like. So longitudinally directed folds, and most marked over the pyloric end of the stomach and along the greater curvature. See, the most marked in the greater curvature. That's what you find. And as soon as the stomach distends, they obliterate. They disappear. Okay. Now, if you look at the wall of the stomach, you'll find that the muscles are 3 layers, very well shown in this figure. Outside longitudinal, circular, inside oblique. And this is again just the body, the fundus, and this is the pylorus. We all know that. And what divides the left and the right? Just to repeat, it is basically the incisura and the vertical line, which is at perpendicular to the lesser curvature, vertical line, which is dividing the stomach into the left and the right half of the stomach. Okay. Now, the 3 layers, which is the muscularis propria or the proper muscular layer or muscularis externa, you have the innermost oblique, which is the incomplete layer. Don't find fibers to be complete. Circular layer is continuous with that of the circular muscles out here. Which one? The lower esophageal sphincter and the pylorus sphincter. So that is a circular layer, continuous with that. And the longitudinal, the outermost layer of the stomach is again continuous with that of the esophagus and the duodenum. Okay. Now this muscular layer has got the myenteric plexus of Auerbach. 1. Number 2, the specialized pacemaker cells we all know about. The pacemaker cell in the gastric and the duodenum are they basically situated in the muscular layer, and they also house the pacemaker cells also house the interstitial cells of Kajal, which becomes a very, very important cell when we talk about GIST. The GISTs are basically they arising from these cells, right? So we have to know that these cells are present out there. If you look at the cross section of this, you'll find that the mucosa has got 3 layers to it. So this is basically surface epithelium. Then you got the lamina propria, and underneath you'll have the muscularis mucosa. Together, this forms the mucosa. So mucosa has got 3 layers to it. Anywhere in the body, any part of any endothelium in the body, it has to have the surface epithelium, has got lamina propria and muscularis mucosa. So 3 layers to the mucosa again out here, similar to other parts, right? And in this, in the stomach, the mucosa, macroscopically, you'll find there is a gastric pit. It is indented. The mucosa indented. So this is basically the part we're looking at, and you'll find this indent. That's why it's a gastric pit. And from these gastric pits, they are the gastric glands which are underlying. So the gastric glands are exiting in these gastric pits. So the gastric pits, they are basically representative, or they're basically representative of the starting point of the gastric gland. Now, underneath this muscularis mucosa, you got the submucosa. And underneath the submucosa, now you got the muscle layers starting from inside. Remember, oblique, circular, and longitudinal. Very easy to remember. This is a very, very good figure. And outside, you got the serosa. Okay. Now, if you look at these glands which are inside, these glands would be having cells. I'll show them to you here also. See, the mucous layers, the surface mucous layers, and then the mucous layer, the neck. These are neck cells. They are again mucus out here. So these are predominantly mucus, and then start getting interspersed with the parietal cells, endocrinal cells, and the chief cells, which are 3 major cells, which are found in any part of the stomach, right? It is a different matter that the proportion of these cells would be different in this part, and the proportion of these cells would be different in the pylorus part, right? Now, the gland type that you find, they are usually tubular in character. And we all showed that there was a delicate basement membrane, flattened, transparent endothelial cells, and all of them, all cells can produce bicarbonate, all cells, right? The glands are of 3 types, basically lying in the fundus and the cardia. In the cardia, they are branched, mainly mucus and bicarbonate. They also have the P cells and the D1 cells, which are now being understood and recognized more. Why? We are now knowing about the hunger hormone or the ghrelin hormone. And the understanding of the hunger hormone arose. The need was seen when we started understanding the physiology of bariatric cells. Only then we started understanding ghrelin. Of course, it always existed from time unknown. We all know that. But it gained additional importance when we started understanding the physiology of bariatric cells. And then you have the fundal or the oxyntic glands. They include the body, and they have got they're more tubular, pits are deeper. Why? Because these glands are larger and mainly got parietal cells, the chief cells, and very few endocrinal cells. But as these migrate down, as we migrate down to the pyloric glands, they're more branched, but they're shallow, right? And the G cells and D cells are more. That means basically looking at endocrinal cells out here and hardly any parietal cells out here. So as you go down from the cardia to the pylorus, you'll find that initially mucous cells are everywhere. The parietal and the oxyntic cells are basically more concentrated in the left part of the stomach. And the right half of the stomach, remember again what is dividing? The incisura and the line across, right? So to right of this line, you're having basically what? More branched and cells, which the gland have cells, which are much more specialized endocrinal cells and hardly any parietal cells, right? Now, remember one thing, that the environment in the stomach, we all know, is highly acidic. But remember, it's not bactericidal. It is bacteriostatic. So don't believe that every bacteria which is going into the stomach is going to be killed. No, it is going to be retarded. The growth is going to be retarded. The stomach has a thriving microbacteria, microbiota inside the stomach. But the acid prevents its overgrowth. And then these bacteria, part of them, migrate down into the lower part of the stomach and into the small bowel. The other thing which is very, very good about the stomach is that the mucosal sheds are shed very rapidly, the mucosal cells shed very rapidly, but at the same time, they're reinstituted. There's the process known as restitution of these cells. So they're replaced. As soon as they're removed, they're replaced. And if you look at the cell types, they're all columnar cells, lining columnar cells. And what are the cell types? We were talking about the cells lining the glands, the surface epithelial cells. These are known as the mucous cells. And they make 40% of the total cell population of the stomach. Secondly, mucus, bicarbonate. We already said bicarbonate by every cell inside the stomach. And in addition, pepsinogen 2 is being secreted from this surface epithelial cell. Oxyntic cell, the parietal cell, which is the main cell secreting the acid for you, the parietal cell mass is only 13%. See, 40%, 13%. But they are approximately 1 billion cells. And the amount of gastric secreted is proportional to the parietal cell mass. Into the lumen, these cells secrete what? We all know, acid and intrinsic factor. But remember one thing, that these parietal cells not only make acid, they also make bicarbonate. And this bicarbonate goes in the intercellular space and into the vascular compartment. So into the lumen, it is secreting acid. Into the intercellular space, secreting bicarbonate. I'll show that to you in a figure when we talk about the acid secretion. The next cell that we know is the chief cell, 44%. 44%. So first we had the major content of the mucous cells, almost 40%. A small fraction of the parietal cell mass, 13%. Now you have 44% of chief cells. These are gyromogenic cells clustered at the base of the gland. Usually the lower part has got the chief cells. And what are they doing? They're secreting the enzyme. And which enzyme are we talking about? We are concerned with the major enzyme, the pepsinogen 1 and 2. 2 is minimally secreted out here. Pepsinogen 2, remember, is maximally situated where? In the SEC cells, the surface epithelial cells, right? And the maximum activation of these pepsinogen occurs at a pH of 2.5. But then comes the interesting part, and these cells are only 3%. The endocrine cells we all know about, just 3%. But they have a major role to play. Why? They've got various kinds of cells. G cells, gastrin producing, mainly in the antrum, 50%. ECL, enterochromaffin-like cells. Most important, histamine, found all over the stomach, not only in the pylorus, but this cell is only in the pylorus. P and D1 cells, ghrelin, in the fundus, right? So that is why 50% of the endocrine cells are found, which are found in the pylorus, are G cells, gastrin producing cells. Now look at the physiology. So that is part of the anatomy is enough for us as surgeons. So that's the surgical anatomy talking about. Now looking at the surgical physiology, the acid secretion we should know, the mucosal barrier we should know, the peptides and neuropeptides we just now talked about, and the gastroduodenal motor activity, which are all important as far as the surgeon is concerned. Why we have a lot of patient gastroparesis. You find the post-operative period, the patient has very delayed bowel sounds and he's got a distended stomach. How do we know that? The patient has got Ray's tube inside, and every day we expect the Ray's tube aspirate to decrease, but it's not decreasing. Mic, please. Somebody's mic on. And why is that happening? That is basically happening because there is gastroparesis. So gastroduodenal motor activity is very, very important. And we'll show the applied importance as we go. Now, gastric juice secretion, the regulation, is basically governed by, number one, the basal acid secretion. We all know that acid secretes 24 hours a day. It's not that when you go to sleep, there's no acid in the stomach. No, it is there. Known as BAO, basal acid output. Now, what is dependent upon? It is dependent upon the vagal tone and the basal histamine secretion. And if you look at it, it's 2.5 milliequivalents per hour and maximum in early evening hours. That means when you go to sleep, you have the maximum amount of basal acidity, right? Now, 3 phases of excited secretion. That means once you have stimulus to secretion, the 3 phases to it. Number 1, the cephalic, the gastric, and the intestinal phase. Now it's believed that there are two phases. One is combined as the vago-antral phase, and number 2 is the intestinal phase. The vago-antral phase got the cephalic part. It stimulates only 10 milliequivalents per hour, but it's also only 30%, right? So basically looking at the vagus, which is a main stimulator. Is it less potent? Is it less kind of a stimulus? No. Just remember that it is one of the most potent stimulators. But then why only 30%? 30% because it is a very short duration. So in totality, if you look at the amount of acid secreted because of cephalic phase stimulation, the total acid is less. But it's not a minimal stimulation. It's a maximum stimulation, but for a very short duration. The gastric phase stimulates, releases 50-25 milligrams per hour. And that is the major secretor, 60%. That means you got a 90% secretion in the vago-antral phase. That's why this is a major phase of excitation. Intestinal phase is only 10% of meal-induced secretion. So you eat something, as soon as you eat something, 90% of the acid being secreted is because of the vago-antral phase, and 10% of the acid secreted because of the intestinal phase. Okay? Now, the gastric secretions, if you look at them, you can easily group them into the organic and the inorganic. The organic are the mucus secreted, the intrinsic factor, pepsinogens, the blood group antigens, this should be group, I'm sorry, it's not blood group, the blood group antigens and hormones, right? So just change this is group, not good. Inorganic, we all know the most important electrolytes we all concerned with when we talk about the post-op management of any patient, and the bicarbonate secreted when we are talking about any acid-base balance alteration in a particular patient, right? Now, if you look at the organic secretions, the mucus, which forms the protection for the whole of the gastric mucosa against the highly acidic content inside the lumen, this is basically, and also against the other irritants. Now, this, along with bicarbonate, forms a layer under the mucus layer, which forms the layer under the mucus layer. This is the most protective mechanism that the stomach has against the acidity and the irritants inside the lumen. Number 2 is the intrinsic factor. We are talking about the organic secretions. Normally combines with B12. We all know that this is basically occurring where? In the terminal ileum, right? This combination resistant to microorganisms, and it dissociates where? In the terminal ileum, and vitamin B12 is absorbed, right? Daily requirement 1 to 2 micrograms. This figure is very important. You all note this down. Body store is 2 milligrams. So if you have a deficiency of intrinsic factor today, you can tide it over for the next 3 to 7 years without taking any vitamin B12. Is that clear? This becomes important where? In gastrectomies, post-gastrectomy patients, post-bariatric patients. Even if you don't supplement vitamin B12 for the next 3 years, the patient will not develop pernicious anemia. Why? Because the body store as opposed to the requirement is so huge. 2 micrograms and 2 milligrams. That's huge, right? The difference is huge. So the pernicious anemia will occur only 3 to 7 years later, right? The organic content is also pepsinogen from the chief cells. Now this pepsinogen is an endopeptidase, stimulated by what? Food, and stimulated through the vagus, through the acetylcholine, the most important stimulus for pepsinogen release. Secreted as 2 forms, pepsinogen 1 from the chief cells, pepsinogen 2 also from the chief cells, but more importantly from the SEC, the superficial epithelial cells of the acid-producing and granulin-producing mass. These are the epithelials we are talking about. The activity, we all know, converted to active form pepsin by pH between 1.5 to 2. Maximum activation, maximum activity, not activity, activity at a pH of 2. Inactivated at pH more than 5. The pepsinogen 2 is active over a wider range of pH as compared to pepsinogen 1. And the action, we all know, is hydrolysis of dietary proteins, digestion of only 15 to 20% dietary proteins. Remember, the rest 80% is going to be digested where? In the subsequent part of the GI, gastrointestinal tract, right? Beyond the pylorus. You have the pancreatic enzyme, dialysis, and so on and so forth. So 20% dietary protein is digested or hydrolyzed in the stomach. The rest of it is in the distant part of the bowel. Now, blood group substance, what are you talking about? These are basically the blood group antigens. You have blood group A, your A antigen will also be found in the gastric juice. It is there. The only difference is that there it is a water-soluble glycoprotein. Your blood has the alcohol-soluble lipoprotein. So it is the antigen, the same antigen, but one antigen is in the form of water solubility, the other in the blood is in the form of alcohol-soluble lipoprotein. It's also secreted in the saliva. And 25%, so these are known as secretors. And 25% of individuals do not secrete. That means 75% of us, 70 to 80%, around 75% average, would be having a blood group antigen being secreted in a gastric juice. But 25% of us will not have this secretion. They are known as non-secretors, and these non-secretors have got the lowest substance in their blood. So all those patients who have got lowest substance in their blood would not be secreting the blood group antigens inside there in the lumen, right? So they got lowest substance positive. So lowest A, lowest B positivity, they become non-secretors and you no longer be secreting their antigens inside the blood. Here comes the most interesting part for us as surgeons in the routine, every emergency and everywhere. I've repeatedly driven home this fact in my residence that go and remember this. Never forget this. Sodium 63 milliequivalent, potassium 13, hydrogen 90, chloride 100. This discrepancy between 90 and 100 can easily be explained by the fact that there is chloride also which is bound to sodium and potassium, right? So that is why it is more than the hydrogen. So chloride is not only with hydrogen, because only with hydrogen it would have been 90. But the rest 10 is basically accounted for by its combination sodium and potassium. But remember, I've repeatedly telling all of you why. Why is it important? To calculate the fluid requirement next day. You go for a round in the emergency and you take a round and you decide on the urine output, decide on the gastric output, and you find the RAS tube has emitted or the aspirate is almost, let's say, 405 ml. And I find repeatedly the order given as 5% exo, 5% exosaline. A very, very common order without any thought to what is being done. Why can't we understand what is coming out through the RAS tube? We can only understand that when you know what is coming out of the RAS tube, what is the content of sodium the patient is losing, what is the content of potassium the patient is losing. And what happens as a result? You don't substitute sodium potassium, this patient has prolonged paralytic ileus. Why? He's losing a lot of potassium out here and you're not substituting the potassium to this patient. So remember one thing, in future, don't forget this. Always remember that the RAS tube aspirate is bringing out the gastric juice for you, and that gastric juice is bringing out what? Sodium and potassium, hydrogen and chloride, all coming out. This again becomes important in another clinical scenario, and that scenario is gastric outflow obstruction. The patient is vomiting. He's vomiting. The main predominant presenting feature is what? Distension and vomiting. A presentation of idiopathic hypertrophic infantile hypertrophic pylorostenosis. Recurrent vomitings. What's the child losing? The infant losing? Again, sodium, potassium, hydrogen, chloride. That's why the early alkalosis set up. That's why hyponatremia occurs. That's why hypopyloremia occurs. That's why hypokalemia occurs. And we have to understand that. That part of the human physiology, gastric physiology, is very, very important. Right? And the amount of bicarbonate secreted in the stomach is to the tune of 2.6 millimoles per hour. This is the range is around 0.7 to 8.7. So just note this down for God's sake and remember this always. If you are a surgeon, if you are a physician, if you are a gynecologist, if you are any kind of a doctor, you have to remember this concentration. You may get away with not remembering what is there, what is the constituent of the ileal juice or constituent of jejunal juice. But you cannot get away without remembering the gastric and the colonic. Both of them are very important. Why? In one vomiting, the other diarrhea. You have to remember both of these. Okay? So I can't stress more than this what I've already done. Right. Now this was the most specific figure that I was talking about. It may seem to be a very, very cumbersome figure. A very easy figure to understand. Let's proceed from here. The parietal cell, the acid producing cell. Right? You have a meal. We already said the meal produces what? 30% acid stimulation. Now what does the food do? Immediately we said vagoantral phase, right? Vago means vagus. Vagus stimulated even by the sight and smell of food. Or we all know that from knowledge of physiology. Right from first year. We all know that as soon as we smell something, you have watering of the mouth. Why watering of the mouth? Vagoantral phase. Right? So vagus gets stimulated. What else gets stimulated as soon as the food reaches there? The G cells. Why? Because remember the food has gone from the gastric canal and immediately gone to the antrum. So the food is reaching the antrum before it is actually reaching the corpus. It's reaching the corpus late. Earlier it's reaching the G cells. So it stimulates gastrin. The D cells are found and the ECL cells are found all over the corpus. We already talked about that. I just now told you that the histamine producing cells are all over the body of the stomach. So the D cells get stimulated, they stimulate the ECL cells. D cells release somatostatin, they then stimulate the ECL cells, release histamine. One course complete. The vagus gets stimulated, releases acetylcholine. Second course complete. The third G cell releases gastrin. Now we know that the end point of the secretion is what? The G, gastrin, histamine, and acetylcholine. They also help each other out. It's not only absolutely separate. They help each other out. How do they help them? Each other. The gastrin also stimulates the ECL cell. The acetylcholine stimulates the ECL cell. So in totality, what is happening? The acetylcholine is stimulating the cell by itself. It is also stimulating the ECL cell, helping histamine. Similarly, gastrin is stimulating itself. It's also helping the histamine to stimulate. So ultimately, the three endpoints is the vagal stimulation, the histamine stimulation, and the gastrin stimulation. See, it's a very simple diagram to understand. Very, very simple diagram to understand. Not very difficult. If you understand what is being said in this diagram, right? Now, histamine stimulates by its own H2 receptors. The acetylcholine stimulates by the M3 muscarinic receptors. And the G cells have special G receptors, which are basically the CCK receptors. cholecystokinin receptor. Okay, now we talked about that. This is getting stimulated from all sides. What about gastrin relief? It is only the meal which stimulates it? No. Partially digested peptides and most important, enteral distension. So what is the food doing from you? The food reaching through the gastric canal into the antrum has to distend the antrum. Where it's going to be accommodated? The food is going to distend the antrum. So this antral distension and part digestion of the food by the pepsinogen, they would lead to further stimulation of gastrin relief. So there is a compounding effect on the gastrin. One, the food by itself stimulates, the vagus has stimulus for the G cells, the food stimulates, and the antral distension. So gastrin is being stimulated on all sides, helping the histamine, which is again getting help from all sides. So it is basically a combination. It is helping each other out, Similarly, the acetylcholine or the vagus stimulation also occurs from gastric distension. So the stomach distension, whether it's antral or gastric, also helps out in the secretion of these juices, which ultimately helps in the parietal cell stimulus. What happens inside the parietal cell? We'll talk about the next figure. But at this point, this is very important. What I have depicted in red is that these are inhibitors. And that is basically where we know how to understand, or we understand how to decrease the acid production, how to prevent a complete parietal cell stimulus. And that is how we know how to treat the ulcer disease. Let's take from one side. You do a gastrectomy. Where do you find the maximum G cells? Antrum. Distal gastrectomy is what? We have removed the antrum. You do an antrectomy, we remove the antrum. So we remove the bulk of the cells which are producing gastrin. So that's one method. And initially, if you won't be knowing that, in 80s when we were studying, one of the major surgeries for peptic ulcer, duodenal ulcer specifically, was doing a distal gastrectomy or antrectomy. We used to remove the antrum. And why was that? We knew that it was a gastrin which was housed there, maximum gastrin secreting cells. We remove those cells. So that is one method of decreasing the stimuli to the parietal cell, remove the G cells. This is no longer done. But we know that when we are doing any kind of bariatric surgery, especially when doing a Roux-en-Y after doing a partial gastrectomy, again this comes important, right? But this is not of major importance now, blocking the G cells. But the other is basically blocking the vagus stimuli. And how do we do that? By HSV or parietal cell vagotomy or proximal vagotomy. Or you can do a selective vagotomy. So all types of vagotomy, any vagotomy, is going to cut the impulse out here. So you can inhibit the vagal impulses by doing any kind of vagotomy. You can cut the gastrin secretion by doing any kind of distal gastrectomy or antrectomy. So see, again, very simple. Now you understand what this figure means. Now we come to the end point. And what is the end point? There's something happening in the parietal cell which produces the acid. That's the proton pump. What happens? I'll show you the next figure. But then here is the enzyme which is known as the proton pump. The hydrogen, potassium, ATPase. That is the enzyme you're talking about. Now, if we can block this enzyme, you're blocking the proton pump. So you're blocking what? The final production of the HCl. Now, this inhibition may not be complete. This inhibition may not be complete. This may not be complete. Let's say it's 50% inhibition. None of them are complete. They are partial inhibitors, right? But this, if you can block at the permanent point, the final point where HCl is being produced and secreted, the hydrogen ion, you're doing a complete block of the acid production. That's why it's a proton pump inhibitor, and that's why are the latest entrants. I would not say late now, but they were entrants in late 80s, and they became the gold standard of treating ulcer disease. Why? Because we are basically treating, or we are inhibiting them at the final point. So that is the next inhibitor of the parietal cell, the inhibitor which blocks your pump. And then suppose for some reason you're using these methods, not a PPI, some other acid being secreted, you can neutralize the acid in the lumen. So it's very easy. You can understand now what you can do with ulcer disease. Stage 1, block gastrin. Stage 2, H2 receptors. These were the most commonly used. Ranitidine, cimetidine. What are these? H2 receptor blockers. Very common usage. So these drugs are still being used. Ranitidine is one drug still being used. It's H2 blocker, right? Pirenzepine was not a very commonly used drug, but parietal cell vagotomy or highly selective vagotomy were one of the major cornerstones of doing a surgical treatment for peptic ulcer. But then came the proton pump inhibitors. So these used to block the proton pump. And if at all you want to block the neutralizing acid without using a proton pump, you can utilize acid. So these are the stages of hypoacidity therapy. This is what is happening inside the parietal cell. Not a very good figure. It's just drawn, I think. Anyway, so basically what's happening is you got the parietal cell which has got the water and the carbon dioxide. You have the carbonic anhydrase out here. Building for you what? Carbonic acid. Now what's happening? Hydrogen separate, bicarbonate separate. Now this bicarbonate now has two exit routes, interstitium into the blood. This is what is known as the bicarbonate tide. So now you know what a bicarbonate tide is. Bicarbonate tide occurs when there is maximal production of acid. Very easy to understand. Because if there is no major production of bicarbonate, there will be no bicarbonate tide. And when is bicarbonate being maximally produced? When there is maximum combination of H2 and CO2. When is it being maximally produced? When it requires more hydrogen ions. More hydrogen ions, that means more acid, more bicarbonate. So bicarbonate goes, so this is basically the interstitial space. So from the cell, it would ingress into the interstitial space, and from the interstitium, see here, it goes into the blood. And if you look at the venous output, if you analyze the venous output, the bicarbonate content of the venous output from the stomach phase, you'll find there's a very high content of bicarbonate. This is one of the bicarbonate type of gastric secretion. Okay, now the third, so this is one interstitium to the vessel. The second, or rather I'll call the third one is, see here, bicarbonate layer. So from the interstitium, it comes and lies over the superficial surface of the cell. So now you know that bicarbonate, which is being produced inside the cell, is being or is leaving the cell into the interstitium. From the interstitium, it takes two routes. One over the surface of the cell, deep into the vascular compartment. Okay. Now this was one part of it. Now we are more concerned with the hydrogen ion secretion. So hydrogen built out here. You got this proton pump or the hydrogen potassium ATPase. This is the proton pump. This is a different name. So this is basically nothing but an enzyme system. Proton pump is what? An enzyme. Which enzyme are we talking about? ATPase. What ATPase? Hydrogen potassium ATPase. Now the potassium is dragged inside, and what happens? Exchange for hydrogen. The give and take has to be equal. If you bring a cation inside, you have to give a cation in exchange. So you bring a cation inside potassium, you give out the hydrogen ion. Or let me say, if you want to give a hydrogen into the lumen, you have to drag a potassium inside, right? Because then you have to have a combination out here. Okay. Now, in addition to this, the chloride inside the vascular compartment into the interstitium, into the parietal cell, is now exiting the parietal cell. So now you can have a combination of hydrogen and chloride, give rise to the acid secretion. The basic acid output, I told you, 2.5 milliequivalent per hour. And if you're using an H2 blocker, it decreases 70 to 90%. See, is it 100% decrease? No, no 100% decrease. Can you block the proton pump with 100% decrease? Almost, almost. So that's the difference between H2 blocker and a proton pump. Okay, so this is believed to be part of the protective mechanism against ingested pathogens. So basically, if you think that achlorhydrate is very good for you, no, it is not. It is harmful for you. Why? Because I told you the acid inside the lumen is required for the bacteriostatic effect over the bacteria which have been ingested and which are not allowed, we should not be allowed to thrive inside the stomach. So this is a protective mechanism against ingested pathogens. So you need gastric acid. You need gastric acid. Okay? So that's the physiology of the gastric acid production. Then you have the peptides, the gastrin, the somatostatin, the gastrin releasing peptide, you got the leptin, you have the ghrelin, right? Now, if you look at these, just touching on the important ones, and why gastrin? Because gastrinomas is an important part of the surgeon's armamentarium, understanding gastrinomas and treating it. So we should know what gastrin is all about. The normal value, remember, is 200 picogram per ml. Don't forget this value if you're looking at a gastrinoma diagnosis, especially those of you who want to go in for MCH and gastric surgery, you have to understand, or even otherwise you should know, 200 picograms per ml. The molecular forms are many. You've got the big gastrin, the little gastrin, and the mini gastrin. The most important in the humans is the little gastrin or the G70 gastrin. The 17 stands for what? The number of amino acids. So 17 amino acids in this gastrin, that's why I know G70. And it's metabolized in the kidney, basic hard fat. Now, what is the gastrin release? How it's released? Basically, the physiological stimulus gastrin release is by the food. We already said that, stimulating the G cells, right? Direct action of acid alcohol protein on G cells. Mechanical extension, remember I told you in that figure just 2 slides back. Dietary amino acids, which are peptides, partially digested, they are most potent stimulus and vagal stimulus. See, but not a main mode in human, but then it does play a role. Physiological inhibitor, how can you inhibit it? By acidity of the antron. The more the acidity, the less the production of by the G cells. Because G cells produce less acid. Produce less gastrin. If you produce less gastrin, less acid secretion, right? So if you have a high acidity content inside the stomach, they would be inhibitors for gastrin secretion. Peptides of secretin family, secretin glucagon, they all are inhibitors of gastrin production. And the action is basically by paracrine action to somatostatin from the antral D cells. So somatostatin is a generalized inhibitor. Just remember this, you understand all action of somatostatin is a generalized GI inhibitor. Inhibits everything. Inhibits the secretion, inhibits the vascularity, inhibits the action, and so on and so forth, right? Now, medical inhibition of gastrin can be done by H2 antagonists, right? To a great extent. Okay. Now, what does gastrin do for you? It helps in secretion of the parietal cells. We did indirectly by stimulating the release of histamine. Remember that figure? From gastrin, we said, from the gastrin here to the histamine here, and from histamine to the parietal cell. So, by stimulating the release of histamine from the ECL cells, stimulate pepsin secretion by chief cells, increase gastric mucosal blocking factor, increase pancreatic secretion, and trophic action on stomach and duodenum. So, all these are actions of gastrin. Have to remember these. Okay. Now, the problem with us is that we have to have patients, or we have patients who have a increased gastrin secretion, hypergastrinemia. What are the causes? The most important we understand is Zollinger-Ellison syndrome. We all know the syndrome. It's always a long gastrinoma. And we know the gastrinoma triangle. I'll just show you in the next slide. Pernicious anemia. Again, a condition where you have increased gastrin. Why? Loss of acid inhibition to G cells by antral exclusion. So there's less of acid, so more of G cell stimulation, so more gastrin. Chronic renal failure. Why? I told you, remember, metabolism where? In the kidney. No metabolism occurring. So more of gastrin inside the circulation. Pyloric obstruction. Why? Antral distension occurs in pyloric obstruction. After ergotomy. Why? Vagal inhibition is released. It's not being inhibited anymore. Gastric ulcer. Why? Because of decreased acid levels in this condition. So normal acid inhibition is lost. In duodenal ulcer, normal gastrin level, but rise of gastrin is more than normal in response to a standard meal. This is what is one of the major causes and effects, both a cause and an effect of a duodenal ulcer, right? See, this is the gastrinoma triangle. I found this a very good figure. And this is basically, the top of the triangle is basically the junction between the cystic and the CBD. See, this is, you can find this. And the second arm of the triangle is basically the junction between the second and third part. See the duodenum curving out here? First part, second, and this is the third, and here the fourth part. So the junction between second and third, and basically if you combine these in a draw straight line, the junction would be at somewhere in the junction of the body and the tail. See? Head and the body of the pancreas. And if you look deep down, this would be represented by the superior mesenteric artery. So head and body out here, junction cystic and the CBD, and the second and third part of the duodenum. This is the gastrinoma triangle. Why gastrinoma triangle? Because the major concentration of G cells will be found in this triangle. That basically tells you that not only the antrum which houses the G cells, they also be housed in a major way by the lines the duodenum and the pancreas. Right? The pancreas, stomach. Most commonly in the gastrinoma triangle. And this gastrinoma triangle is housed mainly in the duodenal tube. Right? G cells are Brunner's gland. This is basically found in the wall of the duodenum. Either sporadic or part of MEN type 1. So gastrinoma syndrome is either a sporadic syndrome or it could be part of a larger syndrome, the MEN type 1 syndrome. You'll find multiple sites of gastrinoma or just one single site. Some of them are malignant, and if they're malignant, they can run an indolent course. So that means you can forget about them, just depress the gastrin secretion and forget about them. Why? Because it's a very, very slow growing course. Indolent basically means what? Very slow growing. If outside the triangle, suppose they found out here, they are much more malignant. So that means inside the triangle, less malignancy, less malignant. Outside the triangle, the same thing is more malignant. Right? Now, this syndrome of acid hypersecretion, which occurs from increased gastrin secretion, would lead toward a persistent refractory and often fulminant peptic ulcerations, until the time that we had the PPI. Once the PPI was there, this syndrome was less and less found. We didn't have those intractable ulcers. But if you still have intractable ulcer, always go in for a gastrin level, which is 200 picogram per ml. It should be less than that. It leads to what? Hyperperistalsis and diarrhea. What else? It inhibits the activity of lipase, causing severe diarrhea. And what kind of diarrhea are you talking about? Fatty diarrhea, foul smelling, bulky diarrhea. Now, if at all, if it grows, the malignancy, the liver mets are the primary site, and the treatment is nothing in the initial stages, prolonged high dose of PPI until they become malignant or not controlled by PPI. Then you have to go for excision primary, and even the secondary excision of these gastrinomas help. That means if you got a liver met, you can even go and excise that. You'll have a very good outcome in these patients, right? So that is about gastrinoma. But how do you diagnose the gastroma? We know the triangle, we know everything. So basically the BAO normally, remember 2.5, stimulated acid measurement, stimulus by pentagastrin, telegastrin, we talk about the later slides, but the maximum acid output, MAO maximum acid output under normal circumstances should be somewhere in the region of 10 to 15 milliequivalents per hour. Okay, in gastrinoma, if you look at the same figure, the BAO goes more than 15. From 2.5 milliequivalents per hour to 15 milliequivalents per hour, usually in the range of 30 milliequivalents per hour. And if you look at the ratio of BAO to MAO, maximal acid output ratio, it's more than 0.6. Normally, it's always less than 0.6. And in addition to this, when you're stimulating the body or the gastric secretion or the acid secretion by these enzymes, the pentagastrin, tetragastrin, or histamine, you will not find any marked response. That means whatever was there initially would be there even after stimulation. Why? Because the high gastrin level has already been stimulating the parietal cell maximally. It's there throughout the 24 hours a day. So the PCM is already being stimulated 24 hours a day. It cannot secrete more. So there's more marked response in acid secretion with stimulation by pepsin and pepsinogen, right? Now, somatostatin, I told you, a generalized depressant. Just very short about these peptides, you have to know them. Anti-D cells, and also saw the gastric mucosa, but predominantly anti-D cells. As somatostatin 20 and 14, this is the predominant form. See, inhibit. Just remember one line, inhibitor of all GI functions. Inhibits acetylcholine, acid secretion inhibition, parietal cell inhibition, ECL inhibition, right? And how does somatostatin act? By two, paracranial and endocrinal. We all know paracranial basically means what? It is depressing these cells adjacent to it. So local action. That is paracranial. Endocrinal basically an action to the blood cells, right? So blood cells. So endocrinal, and so these are ductless glands. These are also ductless glands, but here the effect is only in the local area. Endocrinal effect is a systemic effect all over the body, right? So somatostatin has got both paracranial and endocrinal effect. The gastrin-releasing peptide, leptin, and ghrelin are again important. Now we know all about these enzymes, more and more about these hormones when we talk about bariatric surgery physiology. But GRP is basically what we initially understood Bombesin. Bombesin was basically a very interesting name. But this Bombesin was basically seen only in the skin of the frog, so that name was given up. And this now we named a gastrin-releasing peptide. Stimulates both the G and the D cells. Gastrin somatostatin. G is gastrin, D is the somatostatin. Acts as mucosal protective by increasing the blood flow. It's mucosal protective. Leptin, secreted by adipocytes and in the GIT by chief cells. Adipocytes all over the body fat in your body. Anywhere body fat, adipocyte is going to secrete what? Leptin. And this satiety signaling hormone. And this is directly or diagrammatically opposite to ghrelin. Ghrelin is the hunger hormone. This is satiety hormone. This tells you, look, you have had enough. Don't eat more. This says, look, I'm feeling hungry. Go and eat more and more. That's orexogenic. The most important, probably the only major orexogenic hormone in the body. And remember, one of the bariatric or most of the bariatric surgeries do what? They remove the fundus for you. Why? Because the maximum concentration of fundal D cells, they are the secretors of orexogenic hormones, right? So that is basically for science. So secreted from fundal D cells, and they are the hunger hormones. Okay. Now, mucosal barrier is important. We have to understand why this is so. Why? Because we have to understand why ulcer forms, we have to understand why gastric erosions occur, why hematemesis occurs. In certain patients, the patient is there in the postoperative ward, and suddenly what do you find? You find from the rice tube, it was gastric juice, and now suddenly you find blood or coffee-colored exit from the rice tube, aspirate. Now, why is that occurring? Because of erosion formation. Why erosion occurring? Because something happened to the mucosal barrier. So you have to know what the mucosal barrier is all about. The mucosal barrier basically is all about the resistance to the presence of high digestive and acid content inside the lumen. So what is it made of? Number one, the superficial epithelial cells secrete what? The mucus and bicarbonate. That is barrier number one. Barrier number two, the epithelial barrier, which is the epithelial cell membrane. I told you the figure, initially you had the epithelial layer, then you had the lamina propria, and so on and so forth. So this was the cell membrane outside, and the cells are so tightly stuck between each other, nothing can go in between the cells. So the tight junctions between these cells, the epithelial cell membrane, the tight junction between the cells, they prevent back diffusion of hydrogen into the intercellular space. So the intercellular space is not accessible. So the epithelial cell membrane blocks the accessibility inside the cell, and the tight junction blocks the accessibility to in between the cells. So they do not or they cannot break the barrier, and as soon as they break the mucus barrier, what is lying underneath? The bicarbonate. I told you, over the cell surface, you have a layer of bicarbonate, over that you have a layer of mucus. So the acid has to take care of the mucus, then it has to take care of the bicarbonate, only then it can injure the cell. So in any condition where you have gastric inflammation, remember both the bicarbonate, the mucus and the bicarbonate in that order have been affected. Rapid turnover replacement. A cell gets affected by the acid content, immediately the body does a repair. Right? Part of the wall falls down, immediate repair. Get it repaired on the same day. Similarly, what's happening? The restitution process occurs on the margin. Just like in the peritoneum. How does the peritoneum heal? From the surface or from the margin? Margin. Basically, the bottom. The bottom. So if you have a defect of 2 centimeters, you have a defect of 4 centimeters, the peritoneum heals how? From surface. It takes the same time. 1 day, 2 days, 48 hours. You have a defect of 10 inches, you have a defect of 2 inches, same time. But here basically what's happening is you have to have a margin because you don't have a repair coming from there. So this is in contrast to the peritoneum. Okay. So rapid turnover replacement, rich mucosal blood supply, and efferent sensory neurons which send the pain impulses and tell you, look, there's something wrong down there. Just go in for the healing reflex, and that is the protective reflex. So that is how the mucosal barrier is being protected. Okay. Now what helps in this protection? How is it mediated? By the prostaglandins, by the nitric oxide, the epithelial growth factors, the calcitonin gene-related peptides, the hepatocyte growth factors, the histamine, gastro-releasing peptides. Now, where are all these coming from? They all secretions of the endocrinal cells and basically the gastric cells. So they're all being secreted there, and they're all helping out in maintaining the mucosal barrier apart from the other parts. Now coming to a very important part, that's the gastroduodenal motor activity. And what is motor activity all about? Now they are basically sleeping or migrating motor complexes. These sleeping complexes are those which are helping in the migration of the resting secretions. Is it that when you sleep, your bowel sleeps? No, it never sleeps. The secretions are there, being secreted 24 hours a day. The only difference is it is a basal secretion. So these two pacemakers, the migration complex starts from the gastric pacemaker high up along the greater curvature at the rate of 3 per minute, and the duodenal pacemaker, second part, it gets converted to 10 per minute out there. Now these together, intestinal housekeeper. Why they know intestinal housekeeper? Because they keep the house, they keep it clean by what is being secreted, being pumped down distally. That's why intestinal housekeeper. And this helps in the secretion being made to travel 5-10 centimeters per minute to reach the terminal ileum at the rate of 9 per minute. So from 10 per minute goes to 9 per minute, and the content to reach from the duodenum up to the terminal ileum under normal resting circumstances is 1 to 2 hours. Right? A slow work, doesn't have to hurry at all, and that is what is happening. Now, as soon as they eat something, those housekeepers, they are immediately abolished. The body says, look, forget, your work is over. Now I have to have much more peristalsis, and I have to have much more vigorous and much more frequent. So the receptive relaxation has to occur. Why? Because I have to house something more. I have to relax. Initially, I was getting what? A very small amount, like 2 ml of secretion. Now, as soon as the food comes, that itself is, let's say, 20 ml. So I have to relax. So receptive relaxation has to occur, and intermittent contraction of increased rate and contractile activity. So they have to be replaced by what? They have to be more frequent, they have to be more vigorous, and more frequent, right? So two things have to occur. So I have to relax, and then I have to push them more vigorously. Now, this is permitting what? The agitation and mixing of chyme. As the wave reaches the pylorus, it has to mix much more vigorously. And that can only happen if I got much more vigorous peristaltic activity. And the food has to be retropulsed into the stomach. That's what I told you. Comes to the from the esophagus to the pylorus and goes back. So it has to be retropulsed from there. Each contraction produces what? An escape of small quantity of chyme and mixing of remainder. So what is happening out here? It is being mixed, sent back, and once the next comes out here, part of it is already digested. So I'll release that into the duodenum, and rest of it I'll send back. So that is what is happening. So each contraction produces both an escape of small quantity and the mixing of the remainder. Okay, so that is what's happening. From the gastric canal comes to the pylorus. Initially, there's no escape. Everything is mixed and then sent back for digestion to the body and the fundus. Part of it digested, again exercise pylorus, again mixed more. Part of it goes, and what has been already mixed to enough, that is being sent into the duodenum. Okay. Now, the volume released in the duodenum would depend upon what? The viscosity, depend on the amount of food, and the nature. That means liquid feeds are emptied more rapidly. The solid and the semi-solid would take more time for release, right? So the release into the duodenum would depend upon the viscosity of the content, depend upon the amount, and number three, it will depend upon the nature of the content, right? Now this is just see how many are produced. I just want to give you this. You don't have to remember this. Just to tell you, see the number of peptides being released, number of peptides, and from there coming. So the number of it, almost 10 of them. Now they stimulate motility. All these inhibit motility. All these. So if you want to remember, just remember a few of them. I'll skip this. So basically coming to investigations which will help you understand the gastric motility much more better, right? So you have the endoscopy with the contrast and double contrast radiology, with the ultrasonography. These are basically investigations particular to stomach. We're talking stomach only. The CT scan and the MRI, the endoscopic ultrasound, the laparoscopic, the gastric emptying studies, and acid studies. These two are basically studies which had fallen to disrepute even lately, but then they got their own place value, and we concentrating on these more in one of the subsequent slides, right? Now, the OGD contrast study, I'm not going to go into the details of that. That you have to understand from the medicine people, or if at all you want to, there's not your time to go into details, but just to help you understand part of it. This basically you have a patient in whom there's a epigastric pain not responding, given everything to this patient. Till the patient comes back to you, epigastric pain, you suspect that probably I've missed something, let me do OGD. The patient has hematemesis, you have to do an OGD. From it's coming from recurrent vomiting, unexplained weight loss, dysphagia. So all reasons why you have to go in for this endoscopic study. You want to biopsy a suspect lesion, multiple tissue or brush biopsy, you have to do an OGD. Diagnostic for ulcer disease, benign or malignant, I can differentiate on the basis of a OGD. I can even take a biopsy. So that becomes a very important investigation there. I have to look for polyps, an important investigation. Tells me whether the patient has gastritis or not. Tells me the patient has got a gastric divertibility or not. Stricture formation, gastric outflow obstruction. Tells me what is the reason why gastric outflow obstructions are occurring. Now, is it without complication? Remember, no intervention in the body is without complication. Even an injection has got its own complication. Similarly, an OGD can be complicated by perforation. Because the perforation of the esophagus, you don't know how to do OGD, you try to push everything inside, and you go through the esophagus, it doesn't mean this time. Or through the stomach down into the lesser side. So perforation, aspiration. While doing a OGD, the patient vomits and everything goes into the respiratory tract. The patient aspirates. Why? Because you didn't take the care to have the patient nil orally. Or if you doubt, you should have first of all emptied the stomach. If you have not done either of these, the patient has to have aspiration. Respiratory depression. So common complications. There's a whole load of complications. I'm not going to the details. It's just important complications. The next is the contrast, the double contrast, which is a preferred study, the double contrast, and you can do it with a barium or a gastrogram. Better than OGD in certain conditions, like for example, divertically, fistulas, stricture, fistula strictures, small fistulas, you will not be able to diagnose on the basis of OGD. It's always best diagnosed by double contrast. Hiatus hernia size. This tells you there's a hiatus hernia. It will tell you just a large or a small, but it will not tell you the upper extent. Upper extent, a contrast or double contrast will tell you. Differentiating malignant from benign can also be done with a variance. Benign, the rugosity extends up to the edge of the ulcer. Remember that. A benign ulcer from a malignant ulcer can easily be diagnosed on a basis of a double contrast. How? If the ulcer, you break the margins of the ulcer, the rugosities will extend up to the margin if the ulcer is basically benign. There's a uniform depression in the wall located along the left surface. Right? Now, if you got a malignant ulcer, you'll find the rugosity stop at a distance. So if this is the margin, the rugosity will stop here. And there will be an area of infiltration or edema where the rugosity will be absent. So from the margin to the area where the rugosity stops, there has to be a distance. The depression has to be irregular. It's not uniform depression. Right? And can be located anywhere along the lesser curvature or can be located in the parallel or along greater curvature, anywhere. But this, a benign ulcer, usually along the lesser curvature. The endoscopic, the CT MRI, PET scan, gastric security studies, endoscopic ultrasound is now playing a major role. Why? Because you want to local regional staging gastric carcinomas. It's one of the major investigations now. It will tell you the thickness of penetration of the especially if it's a very early growth, whether you have to know it's T1, T1A or T1B. That is basically, it is either the mucosa or the submucosa involved. EUS will tell you. The other studies will not tell you so frankly or so beautifully. So the diagnosis, the T staging, one of the best methods. It also tells you about the lymph node lying just outside, just into the wall, which a CT scan may not be able to tell you. So both as regards the T and the N staging, EUS is now very important when you talk about gastric carcinoma. Assessing response after chemotherapy. Again, a guided biopsy. Again, very important. You got the ultrasound inside the stomach and the needle comes from outside. It tells you, yes, you've hit the site. Take the biopsy from here. So guided biopsy. Better than a guided biopsy with the help of CT. A CT MRI and a PET scan, on the other hand, helps you in assessing and staging. Why? Because M stage can best be told by the CT MRI and PET scan. Early lymph node liver metastasis, about the metastasis in the mediastinum, metastasis in the lung when you're doing a CT MRI of the lung or the thorax. So as far as the M staging is concerned, and the N to a certain extent, CT MRI helps you. M staging will not be told to you by the EUS. So they both have their own places, right? Gastric security studies, they are now less commonly done clinically. Are they given up? No, they are not. One, as an investigation, it is being still done for physiological studies. One, if you want to go in for study of a new drug which has come in, and of course, may be used when you're doing a Zollinger-Ellison syndrome or refractory ulcer disease or recurrent ulcer problem. So they have got their own role, gastric security studies. Now, just a word about gastric security studies. Why? You've been coming across the terms PAO, MAO, and BAO. Now, what do they mean? PAO, VAO, we all know. Basic acid output, 2.5 milliequivalents per hour. That's the overnight fasting. Now you've got stimulation studies, acid stimulation. And how do you stimulate? By IV pentagastrin, tetragastrin, or histamine. I'll just tell you in the next slide how we do it. But then you have, once you stimulate it, you'll have two kinds of data. One, you can have maximal acid output and peak acid output. Do they mean the same thing? Strictly no. They're different. That's why they've been named different. What is maximal acid output? It is a total acid secretion for a period of 60 minutes after administration of gastric stimulant that cannot be increased further. Why? It correlates to the fat cell law. That means I've been given a stimulant, and that stimulant has led to an increased acid secretion. Now, what is done? Every 15 minutes, the acid would be aspirated and logged on that this much acid has come out. How do you do it? That is basically a different matter. Let's forget that. But I'm collecting the acid every 15 minutes. So those 4 15-minute collections would be added up to give me what? A 60-minute secretion. So I have the amount of acid secreted in 1 hour or 60 minutes. Okay, so that is important. That is the maximal acid output. So I've done it the first hour, second hour, third hour, and I see all the 3 hours, and then I see after adding them up which hour has got the maximum. That's the maximum acid output. But what is PAO? It is the highest rate of gastric acid secretion that can be achieved in an individual after injection of gastric stimulant. Calculated as what? The added values of 2 highest 15-minute collections. So you've done 15-minute collection over the first, second, and third hour. From that, pick up the 2 15 minutes which got the highest value, right? Add them and multiply by 2. So that is the peak acid output. So in contrast to MAO, which is a hourly 60-minute, a PAO is basically taking up the two maximum 15-minute equations, multiplying by 2. That gives you the highest 60 minutes. So that is the PAO. So now you know what the difference is MAO and PAO. If not, just note this down. Take a photograph of this if you want, and then you can easily remember what MAO and PAO means. Right? Right. Now, methodology of acid studies. How are you going to do it? The invasive method and the best method, time-tested method, are as two as important. You initially aspirate everything. You stop aspirating. That means nothing comes out. Now you give me what? Now you give me basically stimulant, and now start secreting acid. And now every 15 minutes, after 20 minutes, 30 minutes, every 15 minutes is now going to be. Why? Because the moment I've been given a stimulant, the first minute doesn't give rise to acid secretion. It takes 30 minutes for stimulation to occur. So after 30 minutes, now the acid is taken out by the acid aspiration, or it can also be taken out with the endoscopic aspiration without a rise. So I have the two methods. They're both invasive methods. The stomach has to be intubated. Non-invasive methods, you can use the gastric acid measurement, the pH-sensitive radio telemetry capsule. It's sending signals from inside, and you can measure the signals and tells you how much amount of acid. Or else, an indirect measurement by the serum pepsinogen, and they can use the gastric acid secretion. This pepsinogen level helps to tell you that how much acid being secreted, and that is basically indirect measurement, right? Now, need for acid, I was just talking about that. Why at all do you need it? Number one, hypersecretory state, like for example, peptic ulcer disease, gastroesophageal reflux, gastrointestinal bleeding, increase the morbidity and mortality to these conditions. So this is one condition where you may like to do a hypersecretory acid, and the reason why, because these conditions, they have increased morbidity and mortality. Low acid output, so I have to know this patient low acid output. Why? Because they were predisposed to what? My body not producing any acid. The bacteria, they are going to multiply like it's nobody's business. Keep on multiplying. So I get a lot of enteric infections. Why? The E. coli has not been controlled in the stomach. So multiplied there, and now coming down in very high concentration. The H. pylori. Antidepressant drugs such as proton pump inhibitors have been associated with a higher incidence of gastroenteritis. All kinds. Clostridium difficile infection. Live risk proposition, right? An absent acid marker is a marker of increased risk of developing gastric cancer. So look, the low acid output gives rise to so many spectrum of diseases. So you have to know a patient's got achlorhydria or hypochlorhydria. The measurement may also be required for assessing pharmacological trials. I just now told you want to assess the effectivity of a new drug in the market. I have to know whether it's depressing the acid enough or not. How clinically modifying treatment dyspeptic patients who do not appear to be responding to acid suppressive medication, or differentiating among the cause of fasting hypergastrenemia. So these are all reasons why still there is a place value of acid study, right? Ultrasound study, abdominal, endoluminal, and laparoscopic. All three are important. As far as stomach is concerned, not only abdominal. Remember, a laparoscopic and luminal ultrasound, they're all important. The laparoscope and endoluminal are two different things. The laparoscope you put in, endoluminal put it to a OGD. So three different types of ultrasound which have place value in gastric studies, right? How do they help you? T staging, lymph node staging, M staging, and gastric emptying. So that is why an ultrasound of the stomach is also very important. Gastric emptying studies. How do you look at emptying studies? By doing a gastrograph and emptying, gastric motor activity, gastric reflux with HIDA, that can be done. You give a HIDA scan, it's secreted in the bile, and from the bile, if you find them inside the stomach, it tells you the pyloric is incompetent. So from the duodenum, second part is coming back. How do you reach the duodenum? To the ampulla oblator. So that's second part of the duodenum. Now it's coming to the first part and from there in the stomach. Does it have any reason to be there in the stomach, the HIDA? No, it's not. From the second part of the duodenum, it should go to the third part of the duodenum, right? So that is the motility study, and that is where the important thing is. Repeatedly in the OPDs, I advise barium kneel follow through, and they ask me what time. And I tell them half hour, 2 hours, 4.5 hours, right? Typical. And they don't understand, but they can't understand why this is so. I repeatedly told them the 4.5 hours the time required for ileum, 2 hours basically for the small bowel, and half hours for the stomach. Look, what do the figures say? Liquids, 50% of them are emptying from the stomach in 10 to 15 minutes. I drink only water. I drink juice. I drink a lot of coffee. 50% would be out of the stomach in 15 minutes. Solids, 50% emptying of the stomach in 2 hours. Okay. Now, a normal meal. I'm taking a normal meal. I've had my dinner. I've had my lunch. Now, how does it behave? 50% of the stomach contents, I'll be emptying them in 2 to 5 to 3 hours if everything is normal. And that is why a half-hour film of barium meal follow-through for stomach visualization is probably the best. Why? Because it is giving the maximal concentration of the contents out there. Right? Total emptying of the stomach is taking how much time? 4 to 5 hours. Now you understand why a 6-hour film is diagnostic for gastric outflow obstruction. Now, we not ask why, and you will be able to remember it very clearly. That one of the better method investigating for a gastric outflow obstruction is what? A 6 hours of barium meal or a gastrographin emptying film. Why? By 6 hours, you should have major amount of emptying. Major amount of emptying. Why? 50% already in 3 hours. The rest over 6 hours. But here, what is happening? 6 hours, it is still there. Does it have reason to be there? No. Total emptying into what time? 4 to 5 hours. So this is why it's diagnostic. 50% emptying of the small intestine, 2.5 to 3 hours. Right? 4.5 hour film from the ICG. Now you know why 4.5 films is there. Why? Because if you still find barium in 4.5 hours in the small bowel, it's what? Abnormal. Why? Emptying should have been 2.5 to 3 hours of 50%. Rest over 4 hours. Why is it there in 4.5 hours? It shouldn't be there. If it is delineating even 4.5 hours, there's something wrong out there. There's a problem with the ileocecal wall. Right? Transit through the colon, 24 hours film for large bowel. Why? So the colon takes 30 to 40 hours. And barium can be found even beyond 72 hours in fecal content. And that is what happens. You get a barium enema done in a Hirschsprung's disease, and you operate on this patient 4 to 5 down the line, 5 days down the line, and you find barium is still there, and you can't understand why it's there. Or you've done a patient with a barium meal follow-through study, the colon still has barium after 72 hours. Why? Because there's a transit time required. So the barium can keep on coming out from the colon even after 3 to 4 days. Right? So remember that. So that is why these are important. And the last part of the lecture, I'll be finishing after I finish the Helicobacter pylori, because I want to finish this up to gastritis. The next time or tomorrow, I think we'll be touching on the ulcer disease. So Helicobacter or Campylobacter pylori is gram-negative, flagellated, spiral, non-sporing. Urease producing, adhesin producing, toxin producing. Which toxins? CAG-A, VAC-A cause gastritis and ulceration. Infection rate of 80 to 90% of general population, average of 50%, inversely related to socioeconomic status. Just note these down. These important points which I've tried to collect for you. Usually infection acquires in childhood and can undergo drastic genetic change to each generation, often for the benefit of us. Host benefit. And how is it transmitted? Very easy to understand. Oral to oral. Fecal oral. And that's why family transmission is very important. Parents and siblings seem to play a primary role in transmission. So 80% population, general population, does have Helicobacter pylori on an average of 50%, and that infection was gained at what time? In early childhood. Right? What does it do? Why does it become so important, understanding Helicobacter pylori? First of all, let's understand what it's doing to you. It disrupts the mucosal barrier. By what? By the enzymes I just told you, CAG and VAC. It disrupts the mucosal barrier. It digests the mucosa and the bicarbonate. Now what is happening? The pylori colonizes the mucosa, leading to what? Inflammation of the gastric epithelium of both the proximal and distal stomach mucosa, or it can lead to pangastritis. So either it can involve the proximal part, the distal part, or it can involve the whole of the stomach. So proximal gastritis, distal gastritis, or pangastritis. In addition to this, it will start extracting more cells. And what are these infiltrating cells to the site? Neutrophils, T and B lymphocytes, macrophages, and mast cells. So along with the colonization of the Helicobacter pylori, you also have the accumulation of these infiltrating cells. Right? Some of them acute infiltrating cells, some of them chronic infiltrating cells. Maybe spontaneous clearance. Now body says enough is enough, out. So spontaneous clearance and resolution of gastritis in some patients, especially young patients. But in some, it has become so tenuous, it says, no, I refuse to go. Then what was happening? Persistent inflammation and erosion, leading to what? chronic active gastritis, and this is the primary condition related to the colonization of H. pylori, and that is responsible for all further disease process of Helicobacter. Right? They all result from this chronic inflammatory process. Is that all? No, it's not all. It's also leading to what? It increases the anti-Helicobacter immunoglobulin titers. And that is why it keeps on progressing. My titers to fight it are gone. What else happens? This chronic inflammatory process leads to severe atrophy without bacterial colonization. Okay? There's no bacterial colonization. Now the atrophy is gaining ground. Why? The bacteria are less in amount. So the inflammation should be less? No. It has set in motion a process of what? A decreased anti-H immunoglobulin, but more important, it stimulates as autoantibodies against parasites. That is what it does. That is one of the most important or devastating effects of H. pylori. It devastates or it harms by itself. In addition, it helps to generate autoantibodies against the parietal cell. So now the body's got two-pronged attack. The bacteria itself and the antibodies generated by the bacteria. All those things by the bacteria, when it leads to disruption, attraction of cells, a persistence of infection. In addition, it says to the parietal cell, look, I don't like you. I'm going to produce autoantibodies, and the parietal cell goes first. And that is why what is happening? Severe atrophy. Without colonization, that means the Helicobacter pylori is no longer found in that area. But still what is happening? The cells are dying out, they're atrophying. Why? Because they're being acted upon by the autoantibody. And how does the Helicobacter generate these autoantibodies? By stimulating by the lipopolysaccharide of the layer of H. pylori. It's got a lipopolysaccharide. That is what is stimulating to produce the autoantibody. And if there's autoantibody destruction of the parietal cell, there's going to be hypochlorhydria. At the same time, the urea converts the ammonia into ammonium, which stimulates the G cells to produce gastrin. The third major effect. So one is the effect by itself, the second by the autoantibody, and third by stimulating the G cells. And this is all mediated by what? The initial cytotoxin and later on LPS generated autoantibody. The CAG-A and VAC-A, the products which are mucosal damaging, which is the starting point of H. pylori. Now, how does it manifest itself? Number one, induced ulcer disease, the acute inflammatory process. At the time of inflammation, it can lead to erosion of the mucosa. And where? Usually the site where inflammation is most severe. Patient with decreased acid output, the ulcer will be most commonly found at the gastric transitional zone between corpus and antrum. Remember the area of the incisura? That's the most common site. While if acid production is normal or high, your most severe inflammation is found in the distal stomach, that's the pylorus and proximal duodenum, right? So the site of inflammation would depend upon your basic initial acid production. If it is low, it will be more at the incisional level. If it is normal or high, it will be more at the antral level, what is known distal gastritis and the duodenum, right? The second thing it does is atrophic gastritis. I told you how it is doing that. Intestinal metaplasia and gastric cancer, right? So that inflammation lead to what? I just now told you the parietal cells are going out. Why? They're being destroyed by the autoantibodies. The cells are being killed by the Helicobacter. Into what? The loss of normal gastric mucosal architecture is getting lost. Destruction of gastric glands is occurring. And if healing is occurring, there are not enough healing cells remaining. The restitution process does not help you any longer. So what is happening? Replacement by fibrosis and intestinal type epithelium. That is what is known as the intestinal metaplasia. This is intestinal metaplasia, the starting point of dysplastic changes and cancer. The process of atrophic gastritis and intestinal metaplasia occurs in approximately half of the H. pylori colonized population. Just excuse me for a minute. So it occurs where the inflammation is most severe. Normal duodenal mucosa, you would say there is no acid production. How it get infected? It cannot be infected. We all know that, but still getting infected. Why? Until there is gastric metaplasia in the duodenum, there will be no H. pylori infection. Remember that. So it is the gastric metaplasia in the duodenum, which is the site of the common infection site. This infection can result in the same inflammatory process that was occurring in stomach. The same process sets up out here, right? So duodenal gastric metaplasia is a normal response of the duodenal mucosa to excess acidity. So this is what is happening. The flow chart, see. Normal mucosa, H. Helicobacter pylori gets in here, it's entering. This is what? Chronic active gastritis. I told you the first stage, the persistent inflammation. Now, what happens? Immune response, autoantibody generated, diet, gastrointestinal genetics, etc., 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 all leading to what? Gastric atrophy. Atrophy, achlorhydria, and co-carcinogens lead to what? Intestinal metaplasia. Along with metaplasia, what's happening? Dysplasia. Now what can happen? Gastric cancer. So see, from H. pylori, from a normal mucosa, it sets up the gastric cancer gene. That's clear. So this is basically the whole pathophysiology of the ultimate. Now the clinical disease spectrum. Note this down. Remember this. This is an accumulation of what can be caused by H. pylori. Number one, non-ulcer dyspepsia. Most of you must be knowing it, but nevertheless, just for revision, for those who know it, transient non-specific dyspeptic symptoms such as fullness, nausea, vomiting. One of the presentations of H. pylori infection. But more important, gastritis. And only one type of gastritis? No. 3 types of gastritis because of Helicobacter. One, enteral gastritis. The old name was type B. We were studying type A and type B gastritis. So this we are talking about the type B. The old name, type B gastritis. This was antrum, only the antrum, because of H. pylori. The pan gastritis, chronicity will lead to atrophy and intestinal metaplasia or dysplasia with malignant potential. Why pan gastritis? It's affecting the whole of the stomach. Pan word is whole stomach. So it's affecting the total stomach. Lymphocytic gastritis. The cells which are being attracted now predominantly T cell infiltration. I told you what was getting attracted: the leukocyte, the T cell, the B lymphocyte, the mast cells, etc., etc. Nagusa. Here basically it's only T cell infiltration. So that is lymphocytic gastritis. The ulcer disease, 10 to 20% lifetime risk, right? That means if I get Helicobacter today, 50% of us have it, 10 to 20% lifetime risk of ulcer. What kind of ulcers? Non-specific ulcer disease, gastric ulcer, duodenal ulcer. That can lead to all 3 types. Duodenal, why? Because there has been duodenal gastric metaplasia. The fourth important disease is MALT type lymphoma. Primary gastric lymphoma, less than 1%. And that is despite the fact that stomach is one place where the intestine does not have intestinal mucosal cells. No intestinal lymphoid cells. Normally, the gastric mucosa does not have lymphoid cells. Still, you can get a primary gastric lymphoma. 60 to 80% of patients who get a lymphoma reach complete remission following H. pylori eradication. That is the best part. And that's why in primary lymphomas, one of the treatment modalities is giving PPI to these patients so that you kill the Helicobacter and the lymphoma disappears. This one condition or this one type of malignancy which disappears completely, 100% remission. And seen in, look, 80% of these patients, 10% continue to have minimal residual disease, and remainder they show no response as it keeps on progressing. So that means 10% of these lymphomas will not be affected even by killing the Helicobacter, but 80% will be disappearing completely. And then, of course, the final clinical spectrum, and that is the adenocarcinoma of the distal stomach, seen in 1 to 2%. So remember, non-ulcer, gastritis, ulcer disease, MALT, and adenocarcinoma. Just remember this whole. It's not only that Helicobacter is responsible for ulcer. We know only that it causes ulcer disease, and we don't know anything else. No, it's not that. So remember the whole spectrum, right? The other harmful manifestations are extraintestinal. Is it affecting the stomach only? No. It may also be a cause for ischemic heart disease, type 2 diabetes mellitus, multiple sclerosis, critical proportion of hepatocyte injury in both cancerous and malignant liver disease. Initially, it was believed to be a positive factor for non-alcoholic fatty liver disease, but recently it has been disproved. So forget about this. Periodontitis, very understandable. Why? Because the teeth and the oral mucosa is one of the areas where you find a very high concentration of Helicobacter pylori. Is it all bad, all harmful because of Helicobacter? No. It has its own benefits. It helps the body. It is a suppressor of Mycobacterium tuberculosis. It is protective against GERD and sequelae, which includes what? Barrett's esophagus, esophageal adenocarcinoma. And how did we know that? because the incidence of the Barrett's and esophageal adenocarcinoma decreased in countries where most individuals were infected with H. pylori and they treated H. pylori, the incidence of Barrett's and this esophageal adenocarcinoma decreased. It is also protective against obesity, childhood asthma, inflammatory bowel disease, and celiac disease and ileal inflammation. That is a beneficial manifestation. How do you diagnose it? Obligate urinary activity is probably the mainstay of diagnosis. You have to take care or take help of the urinary activity. One, the urea breath test, the help of atomic 13C or atomic number 14C breath test, but the preferred is the 13. The biopsy. And what can you do with the tissue that you take out? One, you can do a Campylobacter-like organism staining. That is the gold standard. You can take this biopsy for PCR. You can take this biopsy for culture. You can use this biopsy for rapid urea test. So the biopsy is helping you by four methods of analysis of the biopsy: CLO, PCR, culture, and rapid urea. You can even identify the antigen of the H. pylori. And where do you get the antigen to assess? One, serological in the blood, and stool antigen test. It's almost 94% sensitive and 97% specific. See, the high sensitivity is specific. But still, we rely as the gold standard the CLO Campylobacter-like organisms. What's it all about? Very, very simple test. It may seem to be very, the name may be very bombastic, but it's a very simple test. A qualitative assay is based on the detection of urease hydrolase activity of the H. pylori. How do you do? Nothing. You have a test well filled with urea containing gel. You got a gel and you got a pH marker. And you just take the tissue and put it inside that gel. That's the end. That's the end. What are you looking for? The H. pylori, if present in the sample, the urease will do what? It will hydrolyze the urea inside the gel in the well, leading to an accumulation of ammonium ions, that is positivity, pH positivity. So if there is a rise of pH, you come from yellow to magenta in front of you. 48 hours, you have the result. You have not done anything. Taken a biopsy, put inside the well, and forget about it. 48 hours down the line, you come back and see if the yellow color is turned to magenta or not. If it has, that tells you, yes, this biopsy has got H. pylori, otherwise, no. Simple test. The other is also very simple. You just take a capsule, ingest a capsule, which is containing what? 13C labeled urea. This carbon inside the urea has got a carbon with atomic number 13. Swallowed. The H. pylori is present in the stomach. The urea is broken up into nitrogen and labeled carbon. So that means the carbon as carbon dioxide now has got the labeled carbon dioxide. Okay? This carbon dioxide is now being absorbed across the lining of the stomach into the blood. And from the blood into the lungs, from the lungs into the breath. And if the sample of exhaled breath are collected, if you find the positive isotope, you got pylori. If you don't find it, it's not present. Again, a simple test. Just take the urea labeled capsule and look for the positivity of the isotope or negativity of the isotope in the breath. Very simple test. Nothing to be done. Just have to measure it. And now we know how it does that. Right? It's broken up, labeled carbon dioxide. The treatment, we all know, 3-drug combination, PPI, 2 antibiotics. Clarithromycin is one of the mainstay of most combinations. Why? The eradication rate is 90%. So most of the combinations you should find clarithromycin. If any combination doesn't have clarithromycin, that's not a very combination, not a good combination. Resistance is now appearing. Reinfection rate is less than 0.5 still, but with resistance, you will find the reinfection. Just 4 or 5 slides. Just take a bit more because these are again important as we as surgeons. And these are the autoimmune. The old name was type A. The H. pylori, the old name was type B. The reflux, the erosive, the stress, meningeal disease, lymphocytic, and eosinophilic. Lymphocytic, I told you, it's a rare manifestation of H. pylori. Infiltration by T cells, probably associated. So if you do a PPI treatment, this will disappear. Eosinophilic, allergic, very easy to treat, steroid and chromoglycate, which is basically mast cell stabilizer, and disappear. So these two are rare and they have to be diagnosed by a biopsy of the mucosa taken by OGD, and it helps you by the fact that you can easily treat these, right? Now, type A gastritis, antibody against parietal cells causing atrophy of PCM, hypoachlorhydria. So this is basically, I told you, autoantibodies parietal cells, hypoachlorhydria, decreased production of intrinsic factors, malabsorption of vitamin B12 causing pernicious anemia. So hypochlorhydria, pernicious anemia. Antrum not infected, so hypochlorhydria causes could be increased gastrin, leading to ECL hypertrophy, ECL microadenoma. So what is happening out here? Basically, because the acid level is low, so gastrin keeps on secreting. So they become hypertrophied. ECL cell also gets hypertrophy. So ECL hypertrophy, increased gastrin, hypergastrinemia will be found, pernicious anemia will be found over a particular period of time, ECL hypertrophy, ECL microadenomas, and really malignancies. That is the reason why autoimmune or type A gastritis is important. Forget type A, that name is now been given up. Type B, we already talked about that. I'm not going to go back into this. The pan-gastritis, chronic, and patients can develop gastric carcinoma, especially those with pan-gastritis. Okay. Now, reflux gastritis usually seen post-gastric surgery, incompetent pylorus, very commonly post-cholecystectomy. We find a lot of patients post-cholecystectomy coming with dyspepsia, irritation or pain in the epigastrium. One of the reasons pain could be reflux gastritis. Remember that. Don't forget this. You've done a lab fully, everything was hunky-dory, and now the patient says, I've got a pain in the epigastrium. Now, why does the patient have pain? Basically, because of reflux gastritis. That's because of the causes. You have to treat that. You have to look for that. And the treatment is simple. Use a bile chelating agent or prokinetic, right? You have these. So it takes care of that. Erosive or stress gastritis. Erosive, most commonly you're taking these pain relieving drugs for a long period of time. You have a headache and keep on taking them, gulping them by good numbers every day in and day out. You're taking NSAIDs, COSO inhibitors. They decrease what? The cytoprotective PG synthesis. Remember, PG synthesis of prostaglandin synthesis was important for what? Maintaining your mucosal barrier. Not being secreted, mucosal barrier suffers and gets disrupted. Alcohol, you're a drinker, your mucosal barrier goes. Stress, hypotensive ischemia during periods of intense physiological stress. You are a patient who was subjected to, or a patient gets subjected to hypovolemia and hypotension for a long period of time, or you got otherwise stress, mental stress, all of them will give rise to a stress condition which damages the mucosa and helps in hydrogen ion back diffusion with the cell. It diffuses back, leading to gastritis. Other erosions, smoking, 2-time chances of developing DUD as opposed to normal subjects. What is the pathology or pathophysiology of this? Increase in the gastritis secretion due to gastric ulcers. Both of them were responsible for the formation of the ulcer. And there is a decrease in the prostaglandin and pancreatic duodenal bicarbonate secretion decreases. So that's why these patients are at increased susceptibility to acid formation. The other reasons for gastritis could be chemical agents. We all talk about alcohol, aspirin, bile. We all talk about that. Diseases like Crohn's, tuberculosis, burns, septic shock, H.pylori. I just now told you pathophysiology is infectious inflammatory reaction or immune cell infiltration, chemical-induced mucosal damage, and they all cause back diffusion of the hydrogen. So next time or tomorrow we'll touch on stomach part 2, and we talk only about the ulcer disease, and that is the gastric ulcer and the peptic ulcer. And thank you. I think we took 1.5 hours. But if you want to study stomach completely as surgeons, I think we had condensed quite a bit to a very small part. It's very vast. The physiology very vast. I've just tried to pinpoint the important part. So if you have any questions, you can either put on a mic, ask me right here, or you can. The second thing you can do is you can send me your questions either through the WhatsApp or whatever. Any questions? Anybody has any questions? You can switch your mic on, or I think we'll stop here. Okay, so that's all. Thank you for your time. We'll meet again tomorrow, same time, 2 o'clock. The invitation will be going out just now. Pankaj will be posting all these invitations. Thank you.
Yes, sir.